Good morning. Today's topic is on major connectors. Before going to major connectors, I'll tell you what all the parts of RPD. We have a major connector, minor connector, and denture base, denture teeth, direct retainer, and indirect retainer. So now we are going to talk about major connectors. Major connectors can be classified like into two, that is mandibular major connector and maxillary major connector. We are going to see each one by one. So before going that, what is a major connector? A major connector is the component of the RPD that connects the parts of the processes located on one side of the arch with those on the opposite sides. So this is the function, or this is the major connector which connects from one side of the arch to the other side. It is a unit of the RPD to which all other parts are directly or indirectly attached. So next we move on to functions of major connector. So what are the functions of major connector? Unification. The first point is unification. Unification is defined as a partial denture acts as a one unit, and it also connects the various parts. So it is called as unification. Next is stress distribution. Stress distribution is distributing the stress among all other parts of the. It distributes functional loads to both teeth and mucosa. So what are the requirements? Now we go to requirements of major connector. So how the major connector should be. So it should be rigid, non-interfere with soft tissues, which should not impinge on the soft tissues, and run parallel to the gingival margins and cross the free gingival margin at 90 degrees. These are the requirements of major connector. So on the borders of the maxilla, the connector should be placed in a minimum of 6 mm away from the gingival margin. So in the maxilla, the borders of the maxillary major connector should be around 6 mm from the gingival margin. Whereas in the border of the mandible, the connector should be located a minimum of 4 mm below the gingival margin. So it is in the maxilla is around 6 mm, and in the mandible it is around 4 mm. So then the line angles of the maxillary major connector should be smooth and rounded. It should not be sharp. If it is sharp, it is going to get impinge on the soft tissues and it is going to create a problem. Whereas the border should not interfere with speech. The border should not be thick. So if it is thick, it is going to interfere while the patient is going to talk. So some reliefs have to be given. So in case of relief, it is occasionally given in the mandibular major connectors, whereas it is not given in the maxillary major connectors unless the patient has a tori or prominent midline raphe. Okay, so the mandibular major connector should be located or relieved to prevent impingement of the tissues because the distal extension denture rotates in a function. So when the patient is going to bite in the distal extension case on the posteriors, there is going to be the rotation of RPD. So the major connector should not impinge while the patient is biting or when uploading. The major connector should not impinge on the soft tissues, and there should be relief has to be given. So as in maxilla and as in now it is in maxilla, except for a palatal torus or a prominent median palatal suture area, maxillary connectors ordinarily require no relief. So now we move on to mandibular major connectors. After mandibular major connectors, we have lingual bar, lingual plate, sublingual bar, lingual ball with a cingulum bar, and labial bar, and swing lock design. So these are the 6 different types of mandibular major connectors. I repeat again, it is lingual bar, lingual plate, sublingual bar with a cingulum bar, labial bar, swing lock design. Lingual bar with a cingulum bar is also called as continuous bar. So we're going to see one by one. So first we have a lingual bar. This is the most common in the mandible. use whenever it is possible. The shape is around half pear shape with a thin edge towards teeth and minimum of 4 millimeters in width and thickness is around 1.5 to 2 millimeter. Indications: universally used when adequate space is present, so it can be used when lingual bar. Contraindications. So where should not be used. Okay. So anterior teeth severely tilted lingually, that time you cannot use lingual bar. Interfering lingual tori, if the tori is present in the lingual side, it is going to interfere with the tori, then you cannot use your lingual bar. Then where is there a lingual frenum is high attached lingual frenum, which is also going to interfere with the lingual bar. So there you cannot use a lingual bar. So it is contraindicated in when the patient has a tilted mandibular anterior lingually, whereas the patient has a lingual tori or high frenal lingual attachment. In these three cases, we cannot use lingual bar. Now is a lingual plate or linguoplate, lingual bar with extension over cingula of the anterior tooth. It's called as lingual plate, used where a lingual bar cannot be used. This lingual plate is used where a lingual bar cannot be used. So it rests at each end on the lingual plate, prevent forces being directly facially. So it's going to prevent facial when the forces are being directed facially. In case of interdental spacing, step back design is also followed. You can see in the picture, that is, there is a step back where the spacing can be seen through. If the plate is going to fill that space, it's going to look awkward when the patient is smiling. So this is one more design where a step back design is also followed. The patient can, when the patient opens mouth or smiling or speaking, this plate cannot be seen. Next, a lingual plate where can be given, that is indications with potential impingement from lingual bar. When the lingual bar is going to impinge the tissues, that time you can give lingual plate. High floor of the mouth, that is high floor of the mouth is greater than less than 8 millimeter. Prominent lingual frenum is there, it can be given. When lingual tori is also present, that time you can give the lingual plate in. Next is Kennedy's bar, is also called as double lingual bar. This lingual bar with a secondary bar on cingula of anterior teeth. We have two types of bars, as you can see. One is in the lingual side and one is on the cingulum of the lower anterior teeth. There is potential foot trap between two bars. This maxillary major connector. We are going to see maxillary major connector and we are going to see one by one. So before classifying maxillary major connector, there are different types of maxillary major connector. That is anterior posterior palatal strap, palatal plate type connector, single palatal strap, U-shaped palatal connector, that is anterior palatal strap, single palatal strap, anterior posterior palatal bar. This next is palatal bar, is half oval cross section, minimal contact with the hard palate, less support. Uses when it is short span temporary RPD. When it is given as a short span RPD, that time you can use palatal bar. Next is single palatal strap, that is usually used for class 3 and class 4 cases. As we know, Kennedy's classification, that is class 1 is bilateral edentulous area located in the posterior teeth remaining to the natural teeth, whereas class 2 is single unilateral edentulous area located posterior to the remaining natural teeth, and class 3 is in between the two anterior and posterior teeth edentulous space, as class 4 is an anterior section which crosses the midline. So we all know this. So single palatal strap is usually used for class 3 and class 4 cases. This strap should be around 8 millimeter wide, 8 millimeter wide. So it is going to take all the forces. So it should be around 8 millimeter wide for approximately as wide as combined width of maxillary premolar and first molar. So the width should be around combined width of the maxillary premolar and the first molar. It's confined with an area bounded by four principal rests. Next is anterior-posterior palatal bar. This is anterior-posterior AP. It is a narrow AP variation of anterior-posterior bar. So this is double palatal bar connectors, requires greater bulk for rigidity. You need a lot of bulk of the material. That's why it's going to increase the rigidity of the major connector. This is anterior-posterior palatal bar, more objectionable to the patient. Strap connectors provide greater distribution of stresses. So this anterior posterior palatal bar provides greater distribution when the patient is going to bite or giving the increase in stress while the patient is going to bite or occlusion. That is going to create a lot of pressure or a lot of force. So this force is going to be get distributed in this anterior posterior palatal bar. Next is U-shaped or horseshoe-shaped palatal connector. This is a horseshoe-shaped palatal connector. The poor connector, never used unless absolutely necessary, requires a bulk in the rugae area where the tongue requires freedom for rigidity. So it is, so you need a bulk of this material in the rugae area. Because to increase the rigidity of this material, there's a bulk of the material is present on the rugae area. So what happens is if this major connector is given, when the patient is wearing it, the tongue position or the tongue is going to interfere with this palatal connector and is going to cause a problem when the patient is starting to speak or something. So that time it is going to be difficult for them. So it should be properly used or absolutely used whenever it is necessary. So U-shaped or horseshoe-shaped palatal connector, when it's too flexible, allows movement at the posterior when the patient starts to using it or biting or chewing. That time it is going to move, and traumatic to the residual ridge because it is free hand. Because it is in the free end, it is going to move. So it is going to cause residual ridge, traumatic to the residual ridge. Use only where the torus is prohibits other connectors and extend to the posterior limit of the hard palate. Next is anterior-posterior palatal strap. This is maximum rigidity, gives you the maximum rigidity in the maxillary major connector. It has a minimum bulk, used in most cases, and especially torus palate. If the torus is present in the palate, this type of major connector, that is the anterior posterior palatal strap, can be given to the patient. Next is anterior posterior palatal strap indications. It is mostly used in class 1 and class 2 orchids in which excellent abutment and residual ridge support exists, and direct retention can be made adequate without the need for indirect retention. Long edentulous span in class 2 modification, class 1 arches, and class 4 arches. These are the indications where the anterior posterior palatal strap can be given. Next is anterior posterior palatal strap indications. This is inoperable, that is, tori cannot be removed, where the tori present in the palate, which cannot be removed or surgically, or the patient doesn't want to be removed. At that time, it is extend posterior to the junction of the hard and the soft palate. So the only condition preventing its use is when there is an maxillary tori that extends posterior to the soft palate. That time you cannot use this anterior posterior palatal strap. This is palatal plate type connector. This is a full palate. We used to say as a full palate. Covers one off or more of the hard palate. It is going to cover the hard palate totally. Covers one off or more than the hard palate, more of the hard palate. The maximum tissue support it gives because it is widespread, so it is going to give you a maximum tissue support. Connector of choice is long distal extension cases. Long distance, if the distal extension case is very long, that time you can give this palatal plate, this type of major connector. So palatal plate type connectors, it gives you greater stability. You know why? It is has a large space, and large space is covered and is going to give you a stability and stress distribution. Not You cannot be used in palatal tori patient. If the tori is present in the palate of the patient, this full or palatal plate cannot be given to that patient. This palatal plate is also a widespread area. It covers a large space area, so it is going to give you a increased retention option. Palatal plate should be fabricated for uniformly a thin metal, have accurate anatomic reproduction of the rugae, it is going to cover the rugae also. So we have to give the accurate anatomic reproduction of the rugae. It also improves the strength and rigidity of the major connector. Connector should cover some area as complete denture posteriorly, have a large surface area of mucosal contact, improves potential and for retention. Palatal plate type connector forms, we have a cast plate between two or more edentulous area, a complete or partial cast plate that extends posterior to the junction of the hard and soft palate. Another one is an anterior palatal connector with the provision of extending an acrylic resin denture base posteriorly. These are the three types. A cast palate between two or more edentulous area, a complete or partial cast plate that extend posteriorly to the junction of the hard and the soft palate. Next is an anterior palatal connector with the provision of extending an acrylic resin denture base posteriorly. Palatal plate connector indications: abutments are periodontally involved, where it cannot give the whole force on the abutment tooth. Maximum stress distribution is needed. If it is have a flabby tissues, that time you can give this palatal plate major connector, and shallow palatal wall, that time also you can give palatal plate major connector. These are the cases. As you can see, the major connector and without the major connector, so it is going to impinge. Okay, impinging on the soft tissues. As you can see the redness on the soft tissues. These are the reference. Thank you.